Welcome to the Lymphoma Research Foundation's Understanding a Lymphoma Diagnosis webinar. I'm PJ and I'll be the operator for today's call. For today's call, you will hear from an expert speaker and you will have an opportunity to ask questions. If you have any questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you're listening by phone, this link will be sent to your email at the end of the webinar. And now please introduce Sarah Quinlan. Sarah Quinlan is the Senior Director of Programs and Strategy at the Lymphoma Research Foundation. Welcome, Sarah.
Thank you, PJ, and thank you for each of you for joining today's webinar. Before we begin, we do want to thank our sponsors for this webinar, Foundation Medicine and Genentech. And before I turn the program over to our speaker, I wanted to briefly share information with you about the Lymphoma Research Foundation, as access to expert disease information is so important, and we are thrilled to bring you this educational program. The Lymphoma Research Foundation, or LRF, is the nation's largest nonprofit, dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those touched by this disease through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant for today's call, LRF offers a wide range of lymphoma-specific resources, many of which you can access at the bottom of your screen if you are utilizing the web link or via LRF's website, lymphoma.org. But first, I wanted to highlight LRF's helpline, which can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have had similar experiences to give each other strength to meet the challenges they may face. We also offer a wide range of publications that have been reviewed by lymphoma experts to ensure that you have access to the latest lymphoma information. We also have comprehensive books on understanding non-Hodgkin, Hodgkin lymphoma, and CLL. Our mobile app focused on lymphoma is an award-winning mobile app that provides patients and caregivers access to comprehensive content, as well as unique tools to manage their diagnosis. The app is available for free on the Apple App Store and Google Play. Finally, we have a COVID-19 Learning Center on our website with the up-to-date information on COVID-19 that includes webinars, articles, and other resources. And I really hope you take advantage of all these great resources LRF has to offer. And if you have any questions based on the program that you hear today or any other questions afterwards, I encourage you to reach out to our helpline at 800-500-9976 or visit our website, lymphoma.org. We have a wonderful program planned for you today, and I'm honored to introduce Dr. Kieran Dunleavy. Dr. Dunleavy is a hematologist-oncologist and the director of lymphoma professor of medicine at Georgetown University Hospital. And we are so pleased to have you on the program today, and I will hand the program over to you.
Okay, thanks for the very nice introduction, and thanks to LRF for inviting me here today. Over the next 45 minutes, I'm going to talk about understanding a lymphoma diagnosis, and then we'll have about 15 minutes at the end of this to answer any questions, and I'm very happy to do that. So over the next 45 minutes, I'm going to talk a bit about lymphoma biology, which is a pretty complicated area. What are the different types of lymphoma? What causes lymphoma? How common is lymphoma, and how do we measure it, and how do we treat it? So for the vast majority of people, there is no known underlying cause for the development of lymphoma. And this question comes up all the time. people always ask, well, why did I get this? What did I do, or what risk factors did I have that made this happen? But the truthful answer is that in over 90% of cases, we don't know. There are some factors that can put you at a higher risk of developing lymphoma. We know that people who've had prior radiation or been exposed to radiation and pesticides may have an increased risk of developing lymphoma. There may be environmental exposures that put you at higher risk of lymphoma, but this is really not very well understood, and it's difficult to prove this. You really have to do extensive studies to prove that certain environmental factors can cause lymphoma, and it's very difficult to do this. We do certainly know that there are certain diseases that put you at a higher risk of developing lymphoma. We know that people who are HIV positive, for example, have got a much higher risk of developing aggressive lymphoma. It's in the range of 100 times more common if we look at the most common type of lymphoma. There are some medications that can put you at a higher risk of lymphoma. I would say a good example of that is people who have had organ transplants. So people who have had kidney transplants or liver transplants, they're put on immunosuppressive medications, and we know that these are associated with an increased risk of developing lymphoma. There are also congenital conditions and inherited conditions that people can have that can put you at an increased risk. And these are very, very rare, but we do know of some of them. But again, for the vast majority of people, this is not the case, and we don't know what causes the lymphoma. Other than HIV, there are some other viruses and bacteria that can cause lymphoma. There's an organism called Helicobacter pylori, which is frequent to have in the stomach, and this can be associated with lymphomas that arise in the stomach. They're called MALT lymphomas, and it's a really interesting area, and there are some cases of MALT lymphoma that are associated with this bacteria, and when you treat the bacteria, you can eradicate the MALT lymphoma, but that's not usually the case, and people generally need to get some other type of treatment. So how common is lymphoma? If we look at all of the different cancers, lymphoma is the 5th most common cancer. But the incidence of lymphoma is rising. This looks at how common lymphoma is over a 20-year period. And it's certainly rising. And there are some factors that we understand contribute to that rise. Our population in Western countries is aging, and as people get older, they have a higher risk of developing most cancers, and lymphoma is one of those. So if you look at people who are 30 compared to people who are 70, if you're in the 70 age group, you have a much higher risk of getting lymphoma than if you're in the 30 age group.
And while that explains quite a bit of where we are with this, we also know that there are likely to be other factors that have contributed to this rise in incidence of lymphoma, and really many of these are not well understood. There are ongoing studies that are looking at this, but at this point in time, we don't have a good understanding of why lymphoma is on the rise so much. So how does lymphoma present? The vast majority of people who have a new diagnosis of lymphoma will present with enlargement of lymph nodes. We have lymph nodes all over our body. The areas where we notice them the most are in the neck, underneath the arms, which is the axillary area, or in the groin, in the inguinal area. We have lymph nodes in all other areas of the body, but those are areas where if these lymph nodes become enlarged, you can quite easily feel them. So when people have a new diagnosis of lymphoma, or if their lymphoma comes back, it's very frequent that they will say that they have noticed an increase in lymph nodes in one of those regions. But of course, lymphomas can arise in any part of the body, and they can arise in tissues other than lymph nodes. They can arise really in any organ of the body, including the liver, the bone marrow, the brain. But again, the most common presentation is enlargement of lymph nodes. And when people have lymphoma, we always ask them about certain symptoms. These are called B symptoms. And B symptoms are fevers, night sweats, weight loss of more than 10%. And we always ask people about these. Most people don't have B symptoms, but there are certain lymphomas that are associated with a higher risk of having B symptoms, but you can really have them with any lymphoma. But especially aggressive lymphomas are associated with a higher incidence of these B symptoms. One thing that we do notice is that when people have a new diagnosis of lymphoma and they have B symptoms and their lymphoma is treated, if their lymphoma ever does come back down the road and they had B symptoms when they first presented, it's very frequent to have B symptoms when the lymphoma comes back. So you find that lymphoma doctors always ask about, do you have these particular symptoms? As I said, lymphomas can occur anywhere in the body, so there are a lot of other ways that lymphomas can present, and really the list includes hundreds, if not thousands, of different ways that they can present. So most of the time, when somebody doesn't have enlargement of lymph nodes, it's not clear that someone has lymphoma when symptoms start, because the symptoms are really not straightforward, and they could be due to a number of different things. And the only way that you know that you have lymphoma at the end of the day is by having a biopsy. So in terms of the different types of lymphoma, Hodgkin lymphoma is a lot rarer than non-Hodgkin lymphoma. Hodgkin lymphoma makes up 10% of cases, and non-Hodgkin lymphoma makes up approximately 90% of cases. And when we look at non-Hodgkin lymphomas, 80% of these cases are B-cell non-Hodgkin lymphomas, and 10% of these are T-cell non-Hodgkin lymphomas. It is interesting that the division of lymphomas, be they B-cell or T-cell, is different in various regions of the world. And if we look at the incidence of lymphomas in Asia, for example, compared to the U.S., we see differences in the incidence of T-cell lymphoma, for example. T-cell lymphoma is much more common in Asian countries, and there are some B-cell lymphomas that are not frequently seen in Asian countries. So it's interesting that there's a certain geographic distribution of these lymphomas, and really that's not very well understood, but it is the subject of studies, and people are very interested in this question of why are some lymphomas more common in certain regions and not common in other regions. So next, the pathologic classification of lymphoma, and this is a really critical part of the diagnosis, obviously. And as a lymphoma doctor, we deal with the question of pathology again and again, and it's really important that the initial tissue is seen by a pathologist who is expert in looking at lymphoma cases. Lymphomas can sometimes be very difficult to diagnose. One of the challenges is that sometimes we're not able to get a large amount of tissue to make the diagnosis. So when lymphoma presents in certain parts of the body, we're very limited really in the amount of tissue that we can take out. And I'm thinking of one example when people get lymphoma in the chest area, so in the mediastinum. It can be really challenging to take out enough tissue to make the diagnosis easily. So frequently in that situation, and this applies to a lot of young people who have Hodgkin lymphoma or a related lymphoma called primary mediastinal B-cell lymphoma, they need to have the diagnosis made by a core biopsy, which is done by the radiologists under CT guidance, and they really get a very small amount of tissue. And in situations like that, you need a very good pathologist to look at the tissue and to establish what the correct diagnosis is. So very simply, when the pathologists look at the tissue from a biopsy, they look at the tissue slides under the microscope, and the very first thing that they look at is morphology, and that really describes how the cells look. So as shown here with the picture, you can see that there are a lot of lymphocytes, and certain of these lymphocytes are abnormal and they represent a lymphoma. But that's the very first step for the pathologist, and they have a good idea by just looking at the morphology what type of lymphoma it's likely to be. But once they have done the morphology portion of the diagnosis, then they move on to something called immunohistochemistry. And that's where they use certain protein stains to look at the lymphoma cells. And the very first thing that they typically do is they look at stains for B-cell lymphomas and T-cell lymphomas. And the B-cell lymphoma stain, the first one that they do is usually CD20. And for T-cells, there are stains. There are a number of them, but they frequently look at CD3 and CD5. And if these cells have CD20, then they're B-cell. If they don't have CD20 and if they have CD3 and CD5, then they're T-cell. And this is very helpful for the pathologist in terms of saying it's a B-cell or T-cell process. And then they have to do more investigations to determine exactly what type of B-cell lymphoma it is or what type of T-cell lymphoma it is. And if the diagnosis is not made by morphology and immunohistochemistry, the next line of investigation is doing something called cytogenetics and gene expression profiling and other molecular studies. I can give you some examples of this for people who have a new diagnosis of aggressive lymphoma. We often talk about MYC and BCL2. These are genetic abnormalities in the lymphoma, and to check if a lymphoma has got a MYC abnormality, you can actually do immunohistochemistry, but the definitive test is to look at the cytogenetics of the lymphoma, and there's a technology called FISH, FISH, that's easy, and that stands for fluorescent in situ hybridization, and that is a technique that is used to look and see if there is a genetic abnormality, such as a MYC rearrangement or a BCL2 rearrangement. And if you have those rearrangements, and this really applies to people with aggressive lymphomas, then that's called a double-hit lymphoma. And we have now changed our terminology a bit, and we call this a high-grade B-cell lymphoma with a MYC and a BCL2 translocation. The definitions of lymphomas are changing all the time. The World Health Organization has a classification system where they get a bunch of experts from all around the world, and they try to better understand lymphomas and categorize them so that all of us, when we see patients with lymphomas and we're treating them, we can understand them better. That's really the function of that classification. And it's also very important for research and for advancing the field and hopefully improving outcomes for patients. So the WHO classification is really complicated. There are hundreds and hundreds of different types of lymphomas. But I think a somewhat simple way of looking at it or understanding it is that lymphomas can be divided into indolent lymphomas or aggressive lymphomas. And the common indolent lymphomas are lymphomas like follicular lymphoma, and we think of chronic lymphocytic leukemia as an indolent lymphoproliferative process. It is a leukemia by definition because it's called chronic lymphocytic leukemia, but it's really considered to be part of this group of indolent diseases. Aggressive lymphomas then are different, and the most common aggressive lymphoma is diffuse large B-cell lymphoma. There are other aggressive lymphomas as well, such as mantle cell lymphoma and high-grade B-cell lymphomas, and these are very different to indolent lymphomas. One thing is that they're characterized by a very high proliferation rate. So when the pathologist looks at lymphomas under the microscope, the indolent ones have got a low proliferation rate, and that is usually scored by something called the Ki-67 index. And for indolent lymphomas, that will commonly be in the 5% to 20% range. And for aggressive lymphomas, it will be much higher than that and will be over 80% typically. Sometimes we see lymphomas that behave like acute leukemias. These are not very common, but there are lymphomas such as Burkitt lymphoma and B-cell lymphoblastic lymphoma, and also T-cell lymphoblastic lymphoma. These are very rarely encountered, and for lymphoma physicians who see lymphoma all the time, we really only see a few of these cases every year, but they do occur, and they have a unique type of management even compared to most of the aggressive lymphomas and compared to the indolent lymphomas. So shown here are the most common non-Hodgkin lymphomas. The most common lymphoma is diffuse large B-cell lymphoma, followed by follicular lymphoma, and the other lymphomas then are really pretty rare compared to those two. So there are different clinical types, as we said, indolent lymphomas and aggressive lymphomas. And in terms of how those behave, the indolent lymphomas, such as follicular lymphoma and CLL, they progress over years, and they don't always need treatment. The most common of these is follicular lymphoma. So when I see a new patient with indolent lymphoma, it's very common that they have no symptoms. When I ask them about B symptoms, they frequently have no history of B symptoms, and it's a very common scenario where they may just have a history of having noticed a small swelling in their neck or some other region of the body that isn't causing any problems, and then they undergo a biopsy and it comes back showing follicular lymphoma. And it's I think it's always a challenging conversation for everybody if you have an indolent lymphoma where we know that starting treatment immediately is probably not is not necessary and is not going to be helpful. And there's really a lot of uncertainty when that diagnosis happens. A lot of questions that come up are, well, how long have I had this lymphoma for? And we frequently don't know the answer to that. Sometimes people will have noticed some symptoms, or they will have noticed the beginning of a swelling in a region of their body, which can give you some hints as to how long something has been going on. Sometimes people will have had previous scans done, and that's a very objective way of figuring out how long somebody has had lymphoma for. Because if you have had a scan 3 years ago and you now are presenting with a new lymphoma, obviously you can go back and look at the scan from 3 years ago and investigate if there was any evidence of lymphoma on that scan, and that gives you an idea of how long it's been there for. But often people have not had previous scans, so it's very difficult to determine how long the lymphoma has been going on for. I often find in situations like that where someone has a new indolent lymphoma, they don't have any symptoms, we don't know how long it's been going on for. It's very helpful to bring a patient back 6 months after the initial diagnosis and repeat their imaging at that point and establish if there's been any change from the time of diagnosis to 6 months later. And that gives very important information about the behavior of the lymphoma. And if you have a situation where at diagnosis everything is very indolent and then 6 months later things are starting to change and the lymphoma is starting to grow quite significantly, that might really prompt initiation of therapy. But overall, this is not a straightforward area, and we have guidelines that are helpful in terms of informing us if we should highly consider starting treatment or not. But really at the end of the day, there's a lot of clinical judgment and experience that has to go into the decision making of whether or not to start treatment in indolent lymphomas. The case is a lot different in aggressive lymphomas. Aggressive lymphomas need to be treated as quickly as possible. There is no option to watch and wait or to observe someone for a number of months. So depending on the aggressiveness of the lymphoma, therapy has to be started very quickly. For example, and it's rare, but if you have a patient with Burkitt lymphoma, then you oftentimes have to start treatment within 2 or 3 days. With diffuse large B-cell lymphoma, it probably needs to be started within a week or two. So these are the kind of time frames that are required for starting therapy if you have lymphoma. And the most common type of aggressive lymphoma is diffuse large B-cell lymphoma. And indolent lymphomas are thought to be generally incurable, and aggressive lymphomas are thought to be generally curable. I would say that this is now changing. You may have heard some reports in the past few days about the ASH meeting, which is the American Society of Hematology annual meeting, and this year in particular, there was a huge amount of progress made in lymphoma research, and a number of really important trials were presented, and the results were mature, or getting certainly much more mature than they have been before, and to a point I think where they're starting to inform us perhaps on thinking about new ways of treating certain types of lymphomas. And I bring that up because for some indolent lymphomas, there were very good results and outcomes with a lot of the new therapies that are in development at the moment. And some of these new therapies include CAR T cells. There are a group of therapies that are still not approved by the FDA, but in clinical trials they have been very effective, and those those are called bispecific antibodies, and both in indolent lymphomas and aggressive lymphomas, these have been very efficacious and associated with good outcomes so far. And then the staging of lymphoma is, we use this system called the Ann Arbor staging, which is a really old system that has been around for a long time. There are 4 different stages of lymphoma: stage 1, 2, 3, and 4. And I would say that this is not always straightforward, and I think that some people put a huge amount of emphasis on the stage of their lymphoma, and that is very important. But really, I think in a lot of cases, what's more important is the exact type of lymphoma and whether or not it's a lymphoma that's very easily treatable and easily curable. But the stage is important, and we have something as well called for aggressive lymphoma called the International Prognostic Index that looks at a number of different factors that can help to assess how aggressive a lymphoma is. So when we have a new diagnosis of lymphoma, you need to know what type of lymphoma it is, and a biopsy does that. What problems the lymphoma is causing, and history is important. Asking somebody if they have noticed any lumps, if they have any pain, if they've noticed anything else going on. And we also do labs, of course. One of the most valuable lab tests that we do in the diagnosis of lymphoma is the LDH level, and that is frequently elevated when people have aggressive lymphoma. It can be elevated with indolent lymphoma, but not as commonly. And then we do staging, and we used to do CT scans for staging at initial diagnosis, and now that's really been replaced with PET scanning, because PET scanning is more sensitive, and there's a higher chance that it's going to show smaller areas of lymphoma that might not be picked up on a CT scan. We used to do a lot more bone marrow biopsies, and we're, I think, getting to a point where we're doing less and less. And in general, we do bone marrow biopsies only if they're going to potentially change the management. If they're not going to change management, we tend to do them less and less. And since we've started using PET scans, the PET scans can be very helpful in looking at the bone marrow and giving us an indication of whether or not the bone marrow has involvement by lymphoma. This is an example of a PET scan, and you can see that all of these areas here in the neck are abnormal. These orange areas. With a PET scan, before this scan is done, people get an injection of something called FDG, and this is taken up by areas in the body that have active lymphoma. And when you have a PET scan, the radiologist who looks at the PET scan, they score the PET scan according to something called the Deauville score or Deauville criteria. And there are 5 scores, 1, 2, 3, 4, 5. 1, 2, and 3 are generally considered negative, and 4 and 5 are considered positive. So it's really helpful when the radiologist puts these scores on the report, and they almost always do that, and that tells you whether the PET scan is positive or negative. And after knowing where the lymphoma is, the next question, of course, is what is the treatment? What is the best treatment? And what type of treatment should be used? And the treatment really depends, first of all, on the type of lymphoma. The treatment, for example, is very different if you have diffuse large B-cell lymphoma compared to follicular lymphoma. And then it may depend on the stage and other patient factors. And we're in a very interesting era at the moment where we have a lot of new therapies, and over the past few years many of these therapies have been approved by the FDA, and that will continue. So depending on the type of lymphoma you have, there may be novel therapies that are available and that are showing very good results, and sometimes they're FDA approved, sometimes they're not. If they're not approved, these new therapies may be under investigation in certain clinical trials. So clinical trials are always very important for lymphoma therapy to access agents that have not yet been approved by the FDA, as we now have a number of these agents that are very, very effective. And there are a number of different types of treatment for lymphoma. Surgery is really mainly used for the diagnosis of lymphoma. There, of course, are a lot of cancers, and especially solid cancers such as breast cancer and colon cancer, where surgery is a very important treatment modality, but that's really not the case in lymphomas. Other than for diagnosis, surgery is generally not very helpful. There are some rare situations where it can be helpful, but in general, it's not. Sometimes radiation treatment can be used that can be very helpful in early stage lymphoma, and it can be helpful when lymphoma comes back sometimes. We're trying more and more to not rely too much on radiation, and when we use it, we try to use plans that are associated with lower toxicity, because one of the things we've learned about radiation is that it has long-term side effects, and while it can be very effective at getting rid of the lymphoma, depending on where it's given and depending on the dose and various other factors, it can cause secondary tumors. This is particularly important in children and adolescents and young adults who get radiation for lymphomas that are very curable, because they live for a very long time following their treatment. But if they've had a significant amount of radiation, 10, 20, 30, 40 years down the road, they can have a higher risk of getting secondary cancers. So we have been trying as a field to minimize exposure to radiation when we can do that, but still understanding that radiation can be a very important part of treatment for certain situations and for certain types of lymphomas. Chemotherapy is still the cornerstone of treatment for most lymphomas. We do combine chemotherapy with immunotherapy. For B-cell lymphomas, we almost always use rituximab, for example, and now we have a lot of novel agents that are being used as well, and I'm thinking of agents such as the Bruton's tyrosine kinase inhibitors, ibrutinib, acalabrutinib, zanubrutinib, agents like that, and we have a number of different classes of drugs as well that are being used more and more in lymphomas, such as PI3 kinase inhibitors and immunomodulatory agents, and the list goes on and on. But chemotherapy is still a cornerstone of treatment, especially for lymphomas that are highly curable. But we are developing non-chemotherapy approaches, and the important thing is that I think we continue to do that because they can be associated with less toxicity. But of course, they have to be as effective or more effective as the traditional chemotherapy approaches. And then I've talked a little bit about targeted agents. There are more and more of those coming. And as we understand different lymphomas better and better, we're developing agents that target a specific pathway. And the good thing about these is that they have obviously got a very specific focus in terms of what they're treating. And depending on the targeted agent, they can have much fewer side effects than chemotherapy. But I would say that cautiously, because some of the side effects that targeted agents can have are very different, and we still need to be very careful of many of those toxicities that do not appear in the same way that chemotherapy toxicities appear, but they do happen. So we have to be very vigilant when we follow patients who have received certain targeted agents. And then immune therapy is very important. I guess rituximab was the first immunotherapy, but now we have CAR T cells, bispecific antibodies, and the list goes on. And the good news is that there are so many new therapies in development, and I think they're developing faster and faster, and importantly, being brought to clinical trials, and if they're effective, then being approved by the regulatory agencies so that they're accessible to people with different types of lymphomas. And just to conclude before I take some questions, I think that this just shows you an outline of so many different targeted agents for B-cell lymphomas, including CAR T cells that can target CD19, bispecific antibodies that target CD20 and CD3, and then a bunch of other new agents that are in development targeting a number of different pathways. So the area is, as I said, changing all the time in a very good way, and we have more and more targeted agents and immunotherapies that are showing very good effectiveness across a broad range of lymphomas. So I think that's just been about 40 minutes, and we have about 20 minutes for questions and answers. So I'm very happy to answer any of your questions.
Well, thank you so much, Dr. Dunleavy. We'll now open up for the Q&A portion of the program. And just as a reminder, please keep your questions as general as possible so the entire audience can benefit. And if you would like to ask a question, please submit your question through the Q&A box on your screen. And we'll answer as many questions as possible. And if they don't get answered, I highly encourage you to reach out to LRF helpline at 800-500-9976. And I see we already have a few questions in the queue. Dr. Dunleavy, our first question is, can you talk a little bit about Rituxan and the COVID-19 vaccine? I know that's been top of mind for many patients.
Yeah, so, this is obviously a huge question as we go through this pandemic. So not just rituximab, but a lot of biologic therapies, and in particular, rituximab is part of the anti-CD20 monoclonal antibodies. And while rituximab is a very important lymphoma drug because it targets B cells and eliminates those and eliminates lymphoma cells, it also targets normal B cells. So what you see when people have had rituximab is that they really have very low or perhaps no B cells for a few months while they're receiving rituximab, and that actually can persist for a few months afterwards. So the question comes up again and again, what is the effectiveness of the COVID vaccines and the boosters in people who are receiving rituximab or who have recently received rituximab? And I guess to summarize this, our understanding is that if you don't have any B cells, that the effectiveness of the COVID-19 vaccine is going to be significantly diminished. We do, of course, have tests to check antibody levels to the COVID vaccine, and I would say these are somewhat helpful, but they're not perfect. And one thing that they don't measure obviously is the T cell response, which we're learning is also very important when you have been vaccinated for COVID-19. But I think overall our impression is that if you are getting rituximab or therapy similar to rituximab, that the uptake of the vaccine is significantly affected by that. There really are a number of ways that we can look at this, and this tends to be an ongoing discussion in the clinic. There are some people, of course, who have already had the vaccines and then they develop lymphoma, and the question is, what kind of protection do they have against COVID-19? Do they have no protection or some protection? And that will depend on the timing of the vaccines, when they got them, what their B cells were like then, what the change in their B cells has been. When people are in the middle of treatment, they often ask us, well, should I get a booster? Is it going to be effective? And it probably is not going to be highly effective. I don't think I can say that it's going to have zero effectiveness, but is it going to significantly help against COVID-19 if somebody's infected with that, and is it going to help their clinical course? And I think that it's probably not going to help a lot. And in that respect, we now have a number of new treatments that target COVID-19 that are not vaccines, but there are antibody drugs that are available, and I believe one of these was just approved by the FDA a few days ago. So these are another option that can be considered. One of these that was approved in a clinical trial. And again, I would caution that a lot of this data is new and we're still learning a lot about it. But one of those antibodies demonstrated about an 80% reduction in the development of symptomatic COVID-19 in people who received it, compared to people on that trial who received a placebo, so they didn't receive an active agent. This antibody and other antibodies and other anti-COVID treatments are becoming available gradually, and I think for lymphoma doctors, we are learning how all of these are going to fit into how we treat our patients, and that will depend on a number of different factors. So that's a long answer to your question. And I know that the LRF have an ongoing commitment to educational programs that specifically focus on COVID-19, and those are incredibly helpful, and the LRF can tell you exactly when those programs take place, and I think it's really important to have that as we proceed through this pandemic with all of the uncertainties and unknowns that continue, and we try to figure out how best to address the issue of COVID-19 when people are going through therapies such as rituximab.
Great, thank you. And as a reminder, as Dr. Dunleavy had mentioned, we do have a COVID-19 Learning Center on our website that I encourage everyone to check out with not only enduring resources, but we'll be posting upcoming programs as well. And for our next question, we have a question about sugar. Do you recommend limiting sugar intake?
No, I don't. I don't think that there's any evidence to show that eliminating sugar intake is helpful. So no, I don't. I mean, from one perspective, obviously, it's important to maintain good health status as you are being treated for lymphoma, or if you have lymphoma, and it's not a good idea to have a very high sugar level. But I think for people who don't have any problems with diabetes or high sugar levels, I think that having a balanced diet is the most important is the most important approach. For people who are diabetic, having good sugar control is important as you go through treatment, and especially with a lot of lymphoma treatments, we give steroids, and they can increase sugars a lot. So I think that whatever you can do to control your sugar level, if you are diabetic or have high sugars, but for everybody else, there's no evidence to suggest that sugar intake is associated with anything adverse related to lymphomas.
Great, thank you. And for our next question, you mentioned lymphoma is on the rise for older adults. Can you speak to if that's the same for younger adults as well?
Yeah, that's a really good question. It's definitely on the rise for older adults, and the epidemiological data that has been done has looked at that and established that. For younger patients, it does seem to be on the increase as well. It's a bit more challenging to study some of these epidemiological questions in a lot of different age groups, but I would say overall, our impression is that there is a rising incidence of lymphoma in all age groups. And while we understand that there are some reasons for that, such as some of the reasons that I discussed, some people have underlying conditions that can predispose them to lymphoma. I think that in the field we also recognize that there is a rising incidence that we don't understand, and we have not completely sort of got to the bottom of why that is, and what role environmental factors might play, or could there be more of a role for viruses? We do know that some viruses can be associated with lymphomas, but are there others that we don't understand or we don't know about? So it's a very important area, and it is being studied and being researched. So I hope that we will have some more answers on this pretty soon.
Thank you. And for our next question, does lymphoma affect circulation?
It should not affect the circulation generally. With lymphoma, there are, as I said, probably thousands of different ways that it can present. So, of course, there will be very unique situations where it can affect the circulation, but for the most part, no. I would say that the treatment of lymphoma could potentially affect the circulation in some high risk patients, but again, that is not too common. But in terms of what I was talking about, I think that as we move forward with new lymphoma therapies, that's another reason why it's just important that we minimize toxicity from a lot of the agents that have been used in the past, and if we can make them less toxic but keep their effectiveness the same, that's really where we need to go.
Thank you. And we do have a question about Richter's transformation, and if there's any new updates regarding treatment for Richter's transformation.
So Richter's, just to kind of give a very brief overview of Richter's transformation. Richter's transformation is an aggressive transformation that occurs in people who have CLL, and essentially what happens is that they go from having an indolent chronic lymphocytic leukemia to having an aggressive lymphoma that behaves like an aggressive B-cell lymphoma. And there are a lot of, Richter's transformation is very rare, but a lot of the new therapies that are being developed in Richter's transformation are being, a lot of the new therapies that are being developed in lymphomas are being investigated in people with Richter's transformation. There is now some data using CAR T cells in Richter's transformation because Richter's is rare. There's not a huge amount of data, but the data that has been, that has come out so far demonstrates that CAR T cells may be effective in some people with Richter's. There also is data looking at some other approaches, different types of transplants. We don't have a lot of data with bispecific antibodies. There are some trials that have looked at a class of drugs called immune checkpoint inhibitors. Those are drugs like nivolumab and pembrolizumab, and again, because Richter's is rare, we never have a huge amount of data, but it looks like there is some good effectiveness with agents like that. Another class of drugs that are helpful in Richter's transformation are the inhibitors of BCL2, and also a class of drug called PI3 kinase inhibitors. So I would say there are a lot of new therapies that are demonstrating effectiveness in Richter's, but it's going to take us a little bit more time, I think, to have more definitive treatments that we know work very well. And when I'm talking about new therapies that are in development.
Thank you. And speaking of new therapies, there's a few questions regarding T-cell lymphomas. If you could speak to new therapies and novel approaches.
Sure. So, so there are a number of new therapies that are being developed for T-cell lymphomas. One of the challenges for T-cell lymphomas is that they're very rare. About 85% of lymphomas are B-cell and 15% are T-cell. So that makes it quite more challenging to do studies in T-cell lymphomas, to understand them and understand different pathways that are important and that could be targeted in T-cell lymphomas. But there have been, over the last few years, a number of new approaches that are showing good effectiveness in T-cell lymphomas. Some of these approaches are targeting CD30. CD30 is expressed in a high proportion of T-cell lymphomas, and brentuximab is a drug that is an antibody-drug conjugate against CD30, and that is effective in a number of different types of T-cell lymphomas. There is a class of drug called HDAC inhibitors. They're called histone deacetylase inhibitors, and these are very effective in T-cell lymphomas. T-cell lymphomas are quite complex. There are cutaneous T-cell lymphomas and peripheral T-cell lymphomas, and some of these agents have better efficacy in one versus the other. But that is an example of another class of drugs that are being developed. And then there are new types of transplant and CAR T cells that are being developed, but they're really at a very early point in their development for T-cell lymphomas. The development is much further on for B-cell lymphomas. So these are some of the new treatments that are being investigated in T-cell lymphoma.
Thank you. And for our next question, can aggressive lymphomas be classified as curable?
Could you repeat that again? I'm sorry, I just didn't hear the first part. Yeah.
Oh, sure. Can aggressive lymphomas, can they be eventually classified as curable for the treatment options that are available?
Yeah, so definitely. So aggressive lymphomas are curable, and the cure rate varies according to the type of aggressive lymphoma. But if we look at the most common type of aggressive lymphoma, it's diffuse large B-cell lymphoma, and the cure rate for that lymphoma is approximately 70%. Now, at the ASH meeting, which happened this weekend that I was talking about, there were a lot of advances, particularly in diffuse large B-cell lymphoma. There was one big study that showed that if you added an antibody against an antigen called CD79B, that the cure rate was a little bit higher than with standard treatment. And there also was a lot of data with CAR T cells and bispecific antibodies, specifically in diffuse large B-cell lymphoma. But in answer to your question, yes, definitely, aggressive lymphomas are highly curable, and the curability depends on the type of aggressive lymphoma.
Thank you so much. And for our last question, are biopsies necessary, or is a blood test could suffice?
Yeah, so that's a really good question. At this point in time, biopsies are necessary for most lymphomas, and I'm talking about if they come back at initial diagnosis, they're absolutely necessary. There has been considerable advances and development in performing liquid biopsies, where you can detect if there are lymphoma cells in the blood, circulating lymphoma cells. And in clinical trials, the question of looking in the blood and looking at liquid biopsies and seeing if that's an effective way of monitoring treatment and predicting if the lymphoma is coming back is ongoing and really important. And I think in the future, we're certainly moving to an era where we're going to be doing a lot more blood tests to evaluate lymphoma, and there may come a time where we do not have to do as many scans or other interventions, and that would be a lot easier. But that whole area is still, I would say, largely under investigation. I mean, some of these tests can be done in the clinic, but a big question most of the time is what do you do with the information when you get that you get from it. So as we continue to do clinical trials and ask these really important questions, I think we will get to a point where we can use liquid biopsies much more to make clinical decisions.
Well, thank you so much, and I'm afraid we are just at time. I want to thank everyone for joining our call today. We hope you not only found this informative, but hopeful as well. And again, I would like to thank our sponsors, Foundation Medicine and Genentech, for making this possible. Thank you, everyone who submitted a question. If you have additional questions, I encourage you to connect with our LRF helpline at 800-500-9976. And also at the conclusion of this program, you'll receive an email with the program evaluation. And I would ask that once you receive that email, please take a few moments and complete that brief evaluation, as this is really important to LRF as we think about future programming. Thank you again for joining us today. Thank you, Dr. Dunleavy, and have a wonderful day.
Great. Thank you so much for inviting me, and thanks to everybody for listening. Have a good afternoon. Bye.